Hello, everybody. My name's Ed Pavlik. I'm in Lexington, Kentucky, and I'm here today with my friend.
Frank Lawton from London, United Kingdom.
We're here with another edition of GYN Garage, and we're going to consider two papers today that have a lot to do with women and women surgeons. And I think that the best thing we can do here is turn this over to Frank, and will you start with the first paper, please?
Okay, this paper I think is very interesting. It certainly made the headlines in a lot of the newspapers in the United Kingdom because of its findings that patients seem to do better if they're operated on by women than men. And it was in the Times and many of the other newspapers as well. So clearly it hit a nerve here. Before I discuss that paper, I'd just like to go back and look at a couple of others that the same authors using, I think, the same database. They had a paper in the BMJ in 2017 looking at 30-day deaths and readmissions. And really, we're just looking at the sex of the surgeons. And they did a study looking at age, patients, comorbidities, et cetera, and they found, and there's some numbers here, that the female surgeon death readmission complications rate was 11.1%, whereas if you were operated on by a male surgeon, it was 11.6%. Doesn't sound a lot, but with big numbers, it was a statistical difference. Although I think it would be difficult to say to a patient, what are my chances of having a complication if I'm operated on by a female, and I say, well, it's 11.1%, and if it's a male, 11.6%. Statistics don't mean very much to the individual. And although the numbers are statistically different, I don't think really that's particularly important. Interestingly, the authors in this paper showed no difference at all between elective and emergency surgery. And they said something along the lines as, well, in emergency surgery, you don't choose the sex of your surgeon, and in elective surgery, you do. I don't know what it's like in Ontario, but that certainly wouldn't be the case in the United Kingdom. You don't choose the sex of your surgeon. They did it again, the same database, but bigger numbers now, looking at the surgeon and the anaesthetist impact on outcomes. And luckily for anaesthetists, they found that there was no relationship whatsoever between the sex of the anaesthetist and an adverse outcome for the patient. But the paper that we're looking at, this one, in the Journal of the American Journal of Medical Association Surgery, they looked at long-term or more long-term outcomes. So they took 90 days and 1 year outcomes. And again, showed that if you were a male surgeon, your outcome, or if you were operated on by a male surgeon, then the adverse outcomes at 90 days was nearly 14%, where if it was female, it was just over 12%. And at 1 year, the complication rates were 25% if you were operated on by a male, and 21% if you were operated on by a female. And the similar pattern for mortality. The problem is, of course, that now I don't think they can really explain what this difference is about. There's a number of, they refer to two papers that it says, in a sense, that females may have better communication skills, they may have more empathy with the patients. But the two references, one is a New Zealand reference to general practice, and the other one is a French paper about lifestyle, weight loss, dietary things. And I really don't think they can be in any way referred to outcomes where it comes from surgery. The other thing that they haven't looked at is whether the deaths at 1 year or the deaths at 90 days were actually associated with the surgery. The male patients were older. Did they die of a comorbidity, or was it actually some complication of the surgery itself? And they don't have data to report on that. They also don't record surgeon training. They say how long the surgeon has been in practice, but they don't say whether the surgeon was trained or how much practice that particular surgeon has had during the time. It's an observational study, so there's always going to be problems with outcome when it's just an observational study. Can data from Ontario be translated into data from Cape Town, or data from Los Angeles, or data from Copenhagen? And I'm not so sure. Interestingly, another outcome was that the adverse outcomes were more common in regional hospitals rather than in university hospitals or in tertiary hospitals, implying that perhaps it's something to do with other facilities, possibly imaging and or quality of junior staff. And finally, and I think this one's quite interesting, and I think this database is the one that's going to keep giving, because they've now got, I have to look at something like well over 1 million patients in this database. And I think it would be interesting to see, and I suspect they will do it, that with the advent of robotic surgery, are those figures going to change? Because presumably the female surgeon is still in control of the robot, but the robot may not have the same empathy to the patients as the female patient. And more importantly, they've looked at the sex of the surgeon and not the gender. And with gender problems or gender becoming very much part of mainstream zeitgeist, I think that that's going to be an interesting one. And perhaps in 3 or 4 years' time, they'll produce another paper looking at robots and gender as well. I thought it was a very interesting paper. It's clearly important. It's full of holes, but then it's a good paper.
Indeed, Frank, I agree with you. I'd point out that the sample size was not equal. There were about 4 times as many male surgeons in the sample, and one has to ask: does that create a 4 times increase in the things that will not go good? I think if we look at the paper, if we look at the paper, which is what I'm trying to do. There we go. We look at the paper, here we go, finally. We can look at the important table of data that is there. And what I'll point out to you is that it's important because it calculates adjusted odds ratios. And that's where the numbers really start to separate in terms of what's being demonstrated to the reader. And this is that table. And you can see that in the outcome that's only for 90 days, the separation is there, that women outperform men with regard to the measurement categories of death, readmission, and complications. And they do almost to the same extent on the adjusted odds ratios for the longer term outcomes. What's interesting, though, is I'll point out just what Frank said, that the difference between men and women for these outcomes at the 1 year point are about 4%, and for death about 0.8%. That's small, and I say that's small because normally the significant difference is set at 5% or 0.05, and so we're right at the level of people saying that's enough or that's not enough. With that in mind, the interesting thing to look at is how all cases that were being examined fell with their favorability towards women or favorability towards male surgeons. And that's this line here that my cursor is going down. If it falls on the right of that line, the favorability is towards women in terms of the number that's being presented, which is the adjusted odds ratio. And I've highlighted in red all the places where the finding is significant. So one place is, as Frank pointed out, if the surgery occurred in a community hospital. Another place is if it was a woman that was being operated on by the woman surgeon. And the last place is if it were an elective surgery. So there's a lot of places where we're really saying men and women surgeons really are about the same or not statistically different. And that's a good thing because that defeats any feeling about the inferiority of performance by a woman surgeon. At the best, there's a little bit of positive performance by a woman surgeon, but overall, as Frank said originally, it strikes me as this is quite narrow. I'd like to point out one other thing. We're dealing with what's called the adjusted odds ratio.
Yeah.
And that adjustment is based on 2 different things. One is on modeling, so you either choose the Poisson distribution when you model, or the binomial distribution, and the other one is based upon medians. So there's the one thing you can conclude about that is that the data are not normally distributed. They needed these adjustments where they're placed into a linearization, either in the models or by just using the median. And because the effect is small, one has to wonder how much faith we can have in this, besides to say that women are as good as men, okay,
Yeah.
and maybe a little bit better. And I think that's an important thing to say. So Frank, I'm going to wrap it up with that. Do you have any other comments to make on that particular paper?
No, I mean, clearly, if you want to do well, you elect to be a woman and you elect to have a female surgeon. But I think in the real world, we can't do that.
Absolutely. Well, what I'd like to do is to take under consideration a different paper that takes a conclusion that is really quite different. And that's that women, in terms of a scoring system used in the United States called the Press-Ganey system, they tend to undersatisfy the women and that they operate on. Now, this type of surgery is limited to gynecology, and the Press-Ganey outcome that we should focus on here is that the likelihood of recommending the surgeon by the woman who receives surgery to a friend or associate or family member. So when we look at this paper, one of the things that we will find is that right here in table 2, there's a bigger difference that they're talking about, and that is that women are 19% less likely to be recommended to a friend or family member. And that's this number right here, and that's overall. Now, the group in this table that is the most likely to make a recommendation of their surgeon to someone are older people, the people over 63, and the people that are less likely to make the recommendation are people who are Asian people. Now, the consideration too then is where are we going to draw our conclusions? And one of the things that comes to bear is that were things matched between a woman who was Asian and a doctor who was Asian? And when you look at the concordance, basically, if both the physician and the patient was Asian, there was still a lack of likelihood that the doctor would be recommended, that the female doctor would be recommended. Now that all changed with regard to underrepresented doctors and underrepresented patients. And basically, if there was a match between the physician and the patient with regard to underrepresentation in medicine, then there was a high likelihood that the recommendation would be made to a friend or family member. But mostly, this paper is recommending just the opposite: that women are 19% or more likely to be not recommended to a friend or family member. So in the end, we have to look at really what this could mean. The sample size was limited to 15,000 surveys covering 130 physicians. And that may or may not be adequate for solving this particular problem, especially since the p-values were where they were. But if we take it the way the authors have written it, what does it mean? Does it mean that and this is in their discussion, they lean towards an inherent bias against women? And I would say that that's a reasonable alternative, number one. But there's also another alternative, and that's that this represents both a mixture of inherent bias and biased by the quality of care that was received that shapes the decision to recommend. So, and the paper doesn't distinguish between any of these alternatives. So basically, is there an inherent bias? Well, there could be. And does it combine with something else? And that could be too. And that's where I'll sort of leave it. I think for one truth to put out there, since I've received Press Ganey questionnaires after I've received care, I don't always fill them out. And essentially, the real answer to perhaps what the authors are trying to get at is how do you consider the people who don't fill them out? Have they filled them out before? Do they feel it's meaningless? Or do they feel that there's some negative representation that'll reflect back on you and your caregiver? So, Frank, that's all I have to say about that.
Yeah, it's a very interesting paper, isn't it? When I read it, it's a little bit like TripAdvisor. And we know for a fact, well, certainly in the UK, that there are professional TripAdvisor writers, and they spend a lot of time writing about the quality of their hotel stay, or the food that they had at a restaurant, or the Uber cab driver. And I just wondered, rather like you, what the selection bias is here. Are the people that fill in these forms more likely to fill them in because they have a complaint, or they have a thought, they feel that they've been in some way mistreated or not treated as they want? And the people who actually say, oh, well, the outcome was fine, wouldn't bother to fill the paper in because there's nothing that they need to say. There's no sort of political or any other agenda that says you really must say that if you liked your doctor, you must say you did. And I think the push is, of course, that if you didn't like the service, you are more likely to fill that in. Why on earth? And I think there could be some racial characteristics here that why on earth that women doctors with women. I always thought that one of the reasons why I wanted to be a gynecologist was that I would never have any of the illnesses that my patients suffered. So I would have a much more objective view of their treatment and what I was offering. And I wonder if that if you have a female doctor and a female patient, then the female patient's hopes and what won't happen when they are reduced because the female surgeon says, or the female doctor says, I have that, or I understand that, or I know what's going on. I wonder whether that actually is a negative thing rather than a positive thing. And it may be that's what's shown these data up. Who knows?
Well, that's, absolutely a possibility. I think we'll just let it lie right now and let people take the papers as they come.
Yes.
And that really wraps up this time around for Gynec Garage. So I look forward to seeing you again, Frank.
Yeah.
And we'll